Okay, I can see more people here. Good afternoon, Dr. Roman, Dr. Chen, Dr. Huang, Dr. Chen. So we have our case discussion number 2 today going on, and I'm very, very happy to welcome our Ukrainian doctors and our Taiwanese colleagues. And today we will have two cases presentations from two hospitals in Ukraine, one from Vінниці Regional Hospital and one from Kyiv Pediatrics Hospital, number 2. And I would like to begin with Dr. Артем Кравчук, who is a surgical resident in Kyiv Pediatrics Hospital, number 2. And they have prepared two cases for us.
Yeah, hello everybody.
Hello.
Can you hear me?
Yes. Can you share the screen or should I help you out with this?
Okay, you may share screen maybe.
Okay, wonderful.
Share screen maybe.
So, can you see that?
Yep.
Yes.
Perfect. Then we may start.
Our hospital named Kyiv Regional Children's Hospital is a leading multidisciplinary medical institution in our region, and we provide highly specialized care in many in many parts for pediatric population, and our burn part, our burn care started in 2022. So we are young team. Next slide. I am. Yeah. Nowadays there are only two of us. Kirill Voronezhsky, he is specialized pediatric surgeon. Also, he has a specialization of burn surgeon. And I am a resident, third year, and we hope that I will also get certification in the near future. Also, we have intensivists there that are permanently getting training programs in burn specialization, and also we are now involving our experienced rehabilitation unit into our burn routine. Next slide. So now we have only 2 beds on this surgery floor. They are not accommodated to burn patients. And we have beds in ICU that are also not accommodated. But we have plan. We have hope that in very, very near future we will have new operating rooms, especially for burn patients, also for burn wards, and also specialized burn wards in ICU. Next slide. To begin with cases, I want to say that there are 2 cases. All patients are now well, they feel well, and but we weren't as sure how to treat them at first, but maybe we'll discuss now about them. The first patient is a patient with epidermolysis bullosa. It's a group of rare medical conditions that result in easy blistering of skin and mucous membranes. And as you can see on this picture, this patient was delivered from maternity hospital, and he had aplasia cutis on both of his feet, and also multiple blisters around body. Okay, so but pay attention that there is some skin on his feet. As you can see, the 4 and 5th fingers and part of heel have skin. Yeah. Next slide. So our problem was to operate him right away, or wait, or maybe place some skin substitute and wait. And we decided to just have to wait to make dressing and to see what we get after some time. And there was like big challenge to find material for this patient because classic non-adherent dressing is not appropriate for this patient. And we found from in our humanitarian aid this Mepitel. It's like not adherent, but its soft silicone is like super not adherent, you know. And also we used flamazine as usual, and this tubular dressing, as you can see on the slide, it's very helpful because classic bandages are causing friction, blisters, they are like traumatizing, but as you put some soft silicone, put some gauzes, and then this tubular dressing, it works very well. As you can see on this picture, it's like in the aura, and you can see in spite of the fact that we treated him like very careful, he still had so many blisters, and also it was quite difficult to for education of our staff that they should care this child differently. For instance, we were often taught mother staff that if you see that some blister is like developing, it should be punctured in the base of blister. Also, you should tell our dressing nurse and should treat this patient this way, not just to like wait and see what happened next, because these blisters were like expanding dramatically, you know. Next slide. The first picture is 21st day of treatment from burn, and this is his left foot. No, right foot, yeah. And you can see granulation tissue, and it's not. We decided that it wouldn't heal like fine, and we decided to proceed to operation. Another foot looked fine. There was like a very tiny area of granulation tissue without skin, yeah, but still good. And we made autografting, and you can see the second photo is in the OR after autografting, and third is the 10-day after autografting. Next slide. Okay, this is next patient, but I would rather to speak about the first one with colleagues. Would you operate right away, or just wait till till some outcome and then proceed to operation? Because we consulted this patient months after operation, and their main complaint was that that's fine, totally fine, but the feet that wasn't operated, it's like very fragile, you know. The operated foot, it looked fine. It didn't blister, like. But the another foot that we didn't operate on, that was like covered without operation, was covered in blisters like often, you know. What do you think about that?
Oh, sure. Dr. Huang, you can just go on.
Thank you. Thank you for your beautiful presentation. This is a boy baby. Boy.
Yeah, yeah.
Yeah, it's a boy baby.
Yeah.
And so when he presented to to when he presented to the hospital, that the skin was showed multiple ulcers and also multiple blister.
Yeah.
All of her body include hand, feet, and knee. So, uh, so uh, how do you follow the surface area of the disease progression or not? Did you make a record regarding the disease progression or regression? Can you follow the disease activity?
I didn't hear properly. Anna, can you please translate?
Як ви вимірювали, можливо, поверхневу площу ураження і прогрес відповідно цих захворювань? Чи не вимірювали?
Okay, so we made dressing every like 2 or 3 days, depending on the like on the wounds. And we took a lot of pictures. We had to what to compare with, you know, the like previous day and the day 2 days after, and we could see progression, covering with epithelium, you know. And you asked about the area that how we what body surface, yeah, from the from the first day, we like counted that it was about 10% of body area, you know. I mean, aplysia cutis plus some blisters, and this surface was like changing from dressing day to another dressing day. It was like 10% to 15, then again to 10%, and to about 21 day after we got this patient, there like was about only 5% maybe. It was like his only right foot, and we didn't count like very precisely these blisters. We mostly washed at his legs, you know. And when you count blisters, you get different numbers every dressing day, you know. So one day it's like 10%, then 15%, then again 10%, and that varied very like, you know, in numbers, yeah.
Yes, I see. Very clear. And thank you for your presentation. And regarding epidermolysis bullosa, the disease activity will progress or regress. And my opinion is that I did not surgically skin graft until the disease activity stabilize or subside. Because if you treat the wound surgically too early, then the disease activity may still progress, and the denuded skin may come from right hand, left hand, right arm, right knee, left knee, etc. So, most of the disease activity can be controlled gradually after the baby uh, getting aged and well nutrition to support his body. So maybe 2 weeks or 3 weeks or 1 month or 2 months later, uh, the disease activity may subside, and the residual wound at that time, the not healing wound may consider surgically treatment by skin grafting. That's my opinion.
So, we were mainly concerned that if in burn patient, the results are depend on the time of operation, and so as we gained this 21st day, we saw that okay, it's kind of stabilized. There are granulation tissue and wound isn't closing or expanding on both of feet, and we proceed to operation. Yeah.
Yeah,
Okay.
I see. I see. I understand. Because the denuded skin, aplasia cutis, is different from burn wound. When you treating a burn wound, most of the skin was burned and necrosis. So it may become a infection focus. I mean that the necrotic skin on the burn wound may 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 induce bacteria colonization and infection. So in burn wound, I will recommend early treatment, early excise the necrotic tissue. But in this baby case, the wound is not burned, and we can see the picture that his feet is denuded skin that is dry and aplasia cutis. So it may not introduce bacteria or infection so easily compared to the burn wound. So we can wait until the disease activity subside and the skin graft 2, 3, or 4 weeks later. So in your final treatment, it's quite well. All the skin graft will take and the wound heal. By the way, yes, it's very good result. And by the way, I also wanted to, I have a question that when you put on split thickness skin graft, where is the donor side?
Donor side is side of the same leg. It's right side, and we didn't have any problems like blistering or other problems. It healed very well. It's like best. We were also very nervous about donor side, but it healed very well without any complications. No.
Yes, that's great. Congratulations. That's the reason we should delay the operation until the disease activity subside. If you treat the patient too early, then donor site will become another problem.
Mm-hmm. Oh, yeah. Yeah, well, I see. Thank you very much. Yeah.
Hi, Dr. Chen.
Dr. Chen, your
Dr. Chen,
microphone is like muted.
Yeah. Please turn on your microphone, Dr. Chen. Please turn on your microphone.
Okay.
Okay.
As I have very few experience with this kind of newborn disease, but we have many experience regard TEN, toxic epidermal necrolysis, that usually from drug allergy. And I think the first thing we should consider is that the skin defect is split thickness or full thickness. That means is there only the separation of the epidermis from dermis, or is even loss of the dermis there? And usually, if that's like TEN, that sometimes it's just a result of hypersensitivity. And usually the treatment focus will be try to lessen the effect of hypersensitivity. And so we will usually maybe do it a little bit conservatively, just like Dr. Huang said. We use the biological dressing alone, or maybe use portion skin. And if we need to use the auto skin graft from the patient himself, that we will try to use the skin from the scalp. Maybe you could inject some normal setting subcutaneously to make it bulge and try to remove the skin graft. And if you consider that maybe there are dermis underlying still available, you don't have to put the full cover the complete area. Maybe you can use some split meshed skin graft or the skin stamps instead, so that will reduce the needs for the donor site. And if I think if the skin graft here is so wonderful, that I think maybe there are still some skin appendages at the wound base that maybe you could try to use a comparison group, that some cover with skin graft altogether, and some maybe just use portion skin, or maybe just biological dressing to allow secondary healing. And the other thing, but not the main, that usually the skin tension in very young kids, they are very elastic, so that even some full thickness skin defect could be closed later, and maybe when they is about months, several months old, that you could easily put them together. So maybe it's you have some chances not to graft the skin defect very early, and that maybe there's a possibility that when the baby improves in his in whatever in his condition, that maybe there is possible to regrow the epidermis under the dressing. That's my opinion.
Yeah, thank you.
Okay, next
So,
case.
next case maybe, yeah. So then next case is about boy, 16 years old. He was playing with firecrackers and got burned. First time when we got him into operating room, he had multiple powder burns and penetrating tracts in the skin, and also there was a lot of this firecracker material in his skin, and it was mainly on verbal surface and antecubital region of right forearm, and he had also some other minor burns on left hand and left thigh. Next slide. Yeah. So now you can see his main trauma, as you can see on the second and third picture. Now there are tracts that were like 2 to 3.5 centimeters long, and there were lots of them, not only just 2 of this showed on pictures, but on many holes he had this tracts and pockets, and many of these holes were filled with paper, with cardboard, with remnants of gunpowder, I don't know, maybe. And next slide. Yeah, so we miss here picture from 3 days, not 3, but 2 days after trauma. We first day that is on the previous picture, we did some curettage, extracted these materials, and second time in R is the third day after. We also did some curettage, did some necrectomy, did some tangential excision in the areas of deep burn, deep partial thickness part of burn, yeah. And on the first picture, you can see that we also applied NPVP therapy, negative pressure wound therapy. And this picture we took after 5 days of negative pressure wound therapy. We expected to this therapy to do some work to extract secretions, maybe some remnants, and to provide some granulation to fulfill these tract holes, and as you can see also on the first picture, we opened some of tracts, not all of them, but some of them that we considered as that they had more necrotic tissue than another holes. Also, after negative pressure wound therapy, we also end up with curettage of necrotic tissue in these tracts, and autografted with split thickness skin graft. And second picture is 7 days after autografting, and third picture is 12 days after autografting. So You know, we had in mind the fact that we weren't as sure that all the like tracts holes were properly debrided, you know. So as you can see on the first picture, there are holes that fulfilled with like this gray to black tissue, and it was quite difficult to differentiate whether this is necrosis or this is like pigmentation from gunpowder. And so we thought that the best way for this case was negative pressure wound therapy. Yeah, and so that's it. Maybe you have some like opinion about what would be better in this case. Maybe something different from that we done.
Dr. Chen, yeah, Dr. Juan.
Okay. Thank you. Thank you for your beautiful presentation. And I think your treatment is excellent, fantastic, very good. So you treat the wound very quickly, very urgently. So you excise the necrotic tissue, necrectomy, and open the fistulas, open the tunnels of the thread, and keep the wound very clean. So from the first picture, we can see after 5 days of negative pressure wound therapy, the wound bed is very clean. There is no infection sign. So I think you treated the wound very good at the first stage. And then since the wound bed is clean, and then you put the skin graft, and the result is very good. So I don't have I don't have a extra comment. You do a good job and treat very early, and the result is good. And thank you. Dr. Chen?
I think the result is just too good to use the maybe too good result that we may maybe delay or even cut down the needs of skin graft by himself. Like not every part of the lesion are full thickness. So if you could maybe do the regular wound dressing or under the biological dressing, or if you have cadaver skin or the hetero skin graft from the pigs, that is may use as a first step trial dressing. And if it could here by the good attachment and also that the wound seems very stable in the first week, maybe you can wait to see that it maybe more skin appendage in the dermis that will grow by itself, so that it could be possible that by just like after necrectomy after 5 days, that seems not some of them seems already epithelialized, that you could if the remaining skin defect is smaller, that you could let them grow by itself. And but you do it very well, and also that for young man in 16 years old. If he is a female, then we can also try to harvest the split thickness skin graft from the scalp, so that will not leave any scar in the lower limbs, and that's another choice.
Yeah, thank you very much. We also were thinking about that. Not all the area of this burn is like deep, and maybe it would be good to place some, porcine skin. But we thought maybe it would be better to treat more aggressively, because we weren't sure on the fact that he could get some infection, and we were like, okay, it's just better to close up everything quickly, and didn't thought that the person skin would be better. But thank you very much. We appreciate that.
Okay, thank you so much, everybody. If there's no further comment about these cases, which are excellent, we have a final slide here with some social media information from Dr. Kravchuk.
Yeah, this contacts of both of us, Warnerski and me, and our email, if you want, speak with us. Yeah,
I will share this later with the speakers and everybody. Thank you so much. And I think we can continue and move on to Vінниця case. And we have Dr. Chornopershchuk here and Dr. Kravchuk again. I'll share your case in a moment. Okay. There we go. Can you see my screen?
Yes.
Yeah.
Yes.
Yeah. Hello, everyone. My name is Vitaly Kravchuk. I'm the surgeon of the Center of Thermal Injury and Plastic Surgery of the Vінниця Regional Clinical Hospital. And I want to present my clinical case report. Next. Okay, let's start. Patient V, 58 years old, was admitted to our center at it's a little mistake. It's right, it will be in future, but the patient arrived to us at 7 May 2025 with complaints of wounds on the left leg that do not heal for a long time and accompanied by pain. From the analysis, it's known that more than a year ago, the patient noticed the manifestation of small wound defects that tended to increase. Treatment at home is ointments and antiseptics without hints of improvement. After further examination and consultation with the vascular surgeon, a violation of the patency of the vessels of the lower extremities was diagnosed with subsequent successful surgical correction. Our local treatment included treating the wound area with antiseptic solution and covering them with wound dressings hydrogen cloth. Against the background of the treatment, the patient's conditions improved. Signs of inflammatory reaction in the wound areas decreased, but no visible signs of healing were detected. Next. Visual examinations revealed wound defects filled with the granulation tissue and moderate pathological stratification of fibrin and wound extricated in the areas of the left lower leg and foot. In some places, foci of necrosis were detected. The surrounding tissues were moderately swollen and fibrotic. Also, this patient suffers from type 2 diabetes mellitus with the impaired peripheral circulation and obesity of the second degree. Yeah, you can see how this patient would see. Visual examinations revealed wound defects filled with the granulation tissue. Sorry. Next. After field examination, a decision was made to perform surgical intervention, the following volume: wound sanation and skin grafting. The operation itself and the postoperative period were indispensable. The volume of medical support included the introduction of painkillers as needed, parenteral administration of antibacterial drug, and correction of concomitant disorders. Change in the results of hematological studies were related, and the pathogen Streptococcus pyogenes 10 and 70 few per milliliters was identified in the wounds content sensitive to almost all tested antibiotics except minoxidil. Next. During dressing, scenes of skin engraftment were absent, with scenes of the migration and lesions. The intensity of fibrin formation on the wound surface covered with sluggish granulation of pale pink color increased. Scenes of inflammation in this area become more noticeable. Next. Also, we have some problems with donor site wound, the fertilization time of which was 22 days. Next. One of the elements of the treatment was the injection of autologous platelet-rich plasma, PRP therapy, to stimulate wound healing process. Next. Now, it has been possible to achieve a reduction in the size of wound text and the activity of the local inflammatory reaction. Next. The histological picture of tissue change in the wound correspondent to a chronic productive inflammatory reaction. The wounds remain contained with the pathogen Streptococcus pyogenes 10 and 70 few per milliliter, which is additionally confirmed by the results of the study of the microbiological laboratory of the Vінниця National Medical University, Ukraine. Next. And finally, could you please help with further treatment for this patient?
Okay, Dr. Huang or Dr. Chen. Yes, I see the raised hand. Please go on.
Thank you, Vitali, Dr. Vitali, and thank you. So let's review your presentation. Let's review the previous. Is the patient a woman or a man?
It's a woman.
It's a woman.
Yes.
Yeah, it's a woman. And how about her diabetic condition? Is there any diabetic triopathy? Maybe include the retinopathy, neuropathy, or nephropathy. Is there any associated disease from diabetes?
She doesn't have any she also have problem with control the sugar. The normal sugar is 7 or 9, and she doesn't take any injection of insulin, for example. She have a lot of weight, problem with vessels at the back, and also she have a problem with wounds.
Actually, I have a similar experience to treating this difficult wound, and my case is also a senior woman. present with a difficult wound, not healing for 1 year. And she has diabetic nephropathy, so she received renal replacement therapy regularly. And when I check her vascular condition, all of her arteries in leg were occurred. So I need to have a consultation with vascular surgeon to revascularize the leg. And even though I treated the wound with good granulation tissue, very similar with your condition, and I also put on skin graft. The result is the same with you. The skin graft was failed. Yeah, it's very difficult to take. Although the wound bed is good, although the granulation tissue looks healthy. So, that case, I treated the wound again and excised all the surface layer of granulation tissue, and I put on artificial dermis. So I use BTM. You know the BTM, the BTM. So instead of skin graft directly, I prepare the wound bed and put on BTM. Then treat the wound as usual. After 4 weeks, 5 weeks, the BTM engraft very well. Then I skin graft again for the second stage. So after artificial dermis, then the second skin graft successfully, very good. So this case, I have a very similar experience, and my comment is that first, you need to check vascular condition very detailed. Also, take a X-ray of the foot to make sure there are no osteomyelitis, no bony destruction, no bone lesion. And after that, prepare the wound bed and use BTM as a thermal substitute, then skin graft after BTM maturation. That's my opinion. Thank you.
Hello. My suggestion is that usually these kind of aged people with chronic ulcers usually may be related to the vessels, and if sometimes the several arteries in the Nordex may be occluded. But the other possibility is that because I see the pictures that it's over the anterior leg and also above over the tibia bone, and where the perfusion is not so good. So you may use a more not so aggressive, but maybe could do some debridement and to allow the granulation base and the skin defect grow more and more. And if possible, that maybe ask the vascular surgeon to check the condition of the artery or the veins, especially the veins. And if there is a poor venous return from the Nordex, maybe one way is to, if usually there's a vascular surgery in Taiwan that is specialized. Sometimes need to use the stent at the femoral vein to allow a better return of the venous blood. But at least you can use some pressure garment, pressure stockings for the lower legs to improve the venous return. Somehow that if the venous return is recovered, the wound could even heal by secondary. And the other thing is that poor healing of the donor side. For these kind of cases, I would like their skin may be atrophic. That is hard to harvest by dermatome for a nice sheet of pre-thickness graft. Then I prefer to use the full thickness skin graft, maybe from the lower abdomen or even the longitudinal along the medial side. Just there, usually I could see that this lady patient is a little bit obese, and very easily that we could harvest the FTSG from the side or the lower abdomen and close them easily. So there will be very little problem of the donor side healing. And somehow even the patient, they will feel more satisfactory because you had reduced the more obese part of the belly or the size. So usually it's easier, and you can it can easily close the defect by that, and that you don't have to bother to take care of 2 or 3 more weeks for it's re-epithelialized, and the result is even better.
Yeah, thanks a lot. But early in my presentation, I was said this patient was have a consultation and graduated successful surgical correction by a vascular surgeon. Of course, we don't take a patient to treatment without a consultation with a vascular surgeon. All patients by this time. Every time we could.
Yeah, I mean, you could try to use some elastic bandages or elastic band stockings. After
of course, she came to us with elastic bandages on both legs.
Yeah.
Yeah. Very hard case. Very hard case, and nowadays patients continue his treatment, and yeah.
And by the way, if the wound base is very close to the bone itself, sometimes you'd even have to try to use some skin flap or maybe muscle flap to cover the base and then graft it over it.
Yeah, maybe that. Yeah, thanks a lot. And I want to show you my 2 last slides, if it's possible. Yes, once again, we express our congratulations for your support, for including the opportunity to improve the qualification level of our specialists. We remember our internship with Dr. Irina to Taiwan, where we can a chance to see you in life, and thanks for you share your experience. Yeah, and next. And also for your support with medical supplies, and for all your help, for equipment, knowledges. Yes, it's very Thanks a lot.
Yes, thank you, everyone. Thank you to our Taiwanese partners. Thank you, Dr. Cheng. Thank you, Dr. Juan and Dr. Cheng for attending. Thank you, Dr. Roman. Oh, somebody's sharing the screen. Oh, yeah. Wonderful. Okay, thank you for everybody who has been here today and presented the cases, Dr. Kravchuk again, and Dr. Chernopeshchuk. So if there is any more questions from anybody, feel free to ask, and we will finalize our case discussions for today.
Yes, I just have one question.
Yeah.
First, talking about a genetic disease, epidermolysis bullosa, but the baby just born. So I suppose they don't have the genetic test yet, but just by the symptom. So the symptom, I don't know whether are the bullet on the skin or just through the skin. Because the bullet epidermolysis bullosa is skin lesions by trauma, but the aplasia cutis is by congenital. They just don't know why they didn't develop skin. And the first one is systemic genetic disease, almost no cure. So perhaps you can see whether you can find, or they just have both. I don't know.
So, you know, in that case, the diagnosis of epidermolysis bullosa was like defined by symptoms. We couldn't get at the time no genetics, no biopsies, that we couldn't find laboratories that could provide this testing.
Over other place and feel that the trauma is by trauma, not by congenital. They just didn't develop skin.
Yeah. That was like, you know, this was very difficult to not to make trauma, because you know, we have operation, so anesthesiologists say that they should have like a central venous you know, and they also want to fix it by some way and place tegaderm. It's not like used for patients with epidermolysis bullosa, and it traumatizes, other stuff traumatizes, because most of like materials that we used for that patient weren't like for this patient. They were like for regular children, you know. So we couldn't find most of not also materials, couldn't find proper materials for the child, like plasters that don't make this kind of trauma. So we got blisters all the time from like different manipulations. We didn't treat this child now from other like comorbidities. There was only epidermolysis. There is only epidermolysis bullosa, but every time nurses like make some manipulation, they one way or another traumatized the child. Sometime after the patient get to us, they like learned how to treat this patient. Also, we learned, because we didn't have such patients, and in the day of discharge, we didn't have like any blisters, one or two of them on hands, because child always like waving his hands, and it always usually gets traumatized and gets blisters. But at the end, we coped with this kind of unintentional trauma. And we also we discharged this patient that day, on which parents passed exam how they can treat this patient at home. So they made all the dressing, we simulated dressing changes. They passed answers for treating this patient, because we have national recommendations, and also there is Debra Association that has experience with this patient, and we gave this recommendation to parents, and they passed exams. So at the end, it was the child looked like regular one, except of feet.
Okay.
I would also comment that because the lesions are at the distal part of the foot and hands and knees, is that possible that it's due to some abrasion during delivery from the vaginal canal, so that we don't know about the situation of his skin pathology before delivery, but maybe we as I could you could have applied a diagnosis for this baby, maybe that the skin is very just like bubbles, very spongy and easy to be dislocated, so that maybe not congenital skin defect, but just maybe as a result of delivery process. So that maybe it will happen again. And so that we maybe not overdo it, but maybe just pay more attention and patience to the skin lesion. So hopefully that some of these kind of defects, maybe if the skin could be put back, and then use some pressure garment, and hopefully that they will heal by themselves again.
Okay, thank you so much for the comments, the attending, and the cases presentations. So I think we are going to be over with this Zoom case discussions, and we will probably publish it on YouTube for people just to look through once again. And I will send you all the presentations. I think Dr. Huang has some, and I will send the rest for more pictures. Once again, thank you, and have a peaceful day, everyone.
Thank you. Thank you. See you next time.
See you next month, right?
See you next time. See you next time.